right. I did introduce myself. I will be talking about TCD monitoring in cardiac surgery, and I work for Department of Intraoperative Neuromonitoring for Cardiothoracic Surgery at Virginia Commonwealth University in Richmond, Virginia. I have no disclosure, neither financial association with any ultrasound manufacturer. The TCD recordings are used in this presentation they're taken by Compumedic's DWL Doppler Box X and Spencer system. Purpose of neuromonitoring is to identify threats to central nervous system integrity while there is still window to intervene. In contrast to neurosurgery, where the primary risk is typically mechanical or surgical, in cardiac surgery, the primary risk is from malperfusion. Over 20 years and more, we continue to identify unexpected compromises in neurologic perfusion, while conventional monitoring parameters remain normal. During bypass, region of cerebral hypoperfusion is increased related to non-pulsatile flow. Intraoperative TCD monitoring in pediatric setup looks like this. Monitoring starts after bilateral probe placement on temporal indentation and positive pulsatile flow velocity spectra is seen and obtained at depth of 30 to 35 millimeters in pediatric cranium. Other monitors that you have seen on this slide are from our EEG evoked potentials. I will talk about that later. Neuromonitoring responsiveness requires team engagement for success. Surgeon, anesthesiologist, and perfusionist must plan on working together to address neuromonitoring alarms. On this slide, I'm showing our multimodality recordings that include EEG, evoked potentials, near-infrared spectroscopy, transcranial Doppler, and V-import vitals from anesthesia machine or system. On this slide, this is one of our congenital heart patients, a premature born baby, 29 weeks gestation age. We recorded pre-incision baselines for transcranial Doppler and near-infrared spectroscopy for cerebral and spinal nears. And on TCD morphology, you can see absence of diastolic flow, which would be very abnormal for older kids, but not for this age. This kid came in for repair of coarctation of the aorta. Goal of neuromonitoring is optimizing brain perfusion during cardiac surgery. Cerebral hemodynamic abnormality is inferred by assessing the magnitude of change in flow spectral characteristics from pre-incision references, as I show on previous slide. If the insonation angle, vessel diameter, and blood viscosity remain nearly constant, change in mean flow velocity reflects similar change in volume flow shown by Clark et al. In 1996. Since middle cerebral artery that we insonate through temporal window, typically carrying 40% of the hemispheric blood flow, it is favored site for surgical TCD monitoring. A relatively constant blood viscosity may be anticipated, except during major blood loss, hemodilution, transfusion, and hypothermia. However, even in these situations, TCD still may provide valuable information. TCD can detect underperfusion due to inflow obstruction, that is obstruction of aorta, or outflow obstruction, that is obstruction of superior vena cava. Now I will show several slides that shows malpositioning of either of those cannulas. So let's start with malposition of aortic cannula. On this slide, we noticed immediately loss of systolic flow on the left side of TCD. In this case, no other changes in our recordings. So TCD provides immediate feedback in the setting of arterial cannula malposition, as we see here, with decrease in systolic flow. Cannula can be malpositioned into innominate artery, carotid artery, or subclavian arteries, particularly if they're long. This phenomena has informed surgical cannula selection, as some cannulas are more prone to malposition. This is an old picture that I recorded with Dr. Harvey Edmonds. You can see a significant drop in systolic flow, and we informed surgical team immediately this was corrected and continued with surgery. Venous cannula malposition. It is detected by loss or significant decrease of diastolic flow. This is a congenital heart surgery of 3-year-old male patient that came in for the etiology of Fallot repair. Venous cannula obstruction, or SVC, can be related to kinking, clamp left on snared SVC cannula, inadequate cannula size, or even just lifting the heart can immediately be detected by decrease in diastolic flow velocity. Another case of congenital heart surgery, 2-year-old infant with came in for ASD repair. We detected venous cannula malposition with loss of diastolic flow. In this case, other signals change as well, with immediate drop in NIRS, a loss of cortical activity recognized on EEG, and loss of subcortical of deep structures recognized on evoked potentials. 2-year-old female patient came in for VSD repair, venous cannula malposition, again, loss of diastolic flow, immediately recognized. TCD is good in, very good in emboli detection and elimination. It can recognize micro and macro emboli. Emboli at 40 microns adhere to arterial line and tubing of the pump circuit. If those emboli are smaller, they can pass through the filter, go to cerebral circulation, and can be detected only with TCD. So for cardiac surgery, the scenario of microemboli is very typical, and they cannot be detected by perfusion if they're very, very small, because detectors on perfusion system is set to ignore microemboli. Now, we have my colleagues perfusionist online. We can discuss about this, but this is so far, unless they updated the systems at this point. The source of emboli are myriad, and they can be coming from anesthesia, from perfusionist, and from surgical side. Next time I will talk more about what is happening in these occasions. Nearly all emboli occur while the pump bubble detector remains silent. Gas emboli can cause injury even if they don't obstruct the flow. This occurs because gas bubbles cause damage to capillary endothelia. Irritation can initiate the inflammatory process and produce vasogenic edema. Another case, congenital cardiac surgery, the TCD detected flow obstruction after air emboli, and NIRS drop was noted immediately as cessation of the flow to the brain. Of course, this was corrected immediately and continued with surgery. On this slide, massive air emboli recognized bilaterally on TCD. Actually no NIRS change, significant NIRS change in this case. Teamwork immediately, we intervened within 3 to 4 minutes. Everything was fixed. On this part of the slide, you can see the change of the tubing, which was source of the emboli, and emboli were eliminated. Another case of bilateral emboli, this was from suction from the surgical field. No other changes, no systemic changes, this would not be recognized. So if you look at, this is another case actually, where single emboli gradually increased to shower, to curtain, to blast. Now, if this is not stopped, it's gonna end up in neurological deficit. TCD is helpful in management of acid-based strategies during deep cooling. In cardiac cases, alpha-stat technique, which is designed to keep CO2 constant, or pH-stat technique, which is designed to keep hydrogen ions constant by allowing CO2 to increase. Also, navigating deep hypothermic circulatory arrest, DHCA, with neuromonitoring of TCD and NIRS, since other recordings are silent. It can detect correct supplemental retrograde or selective antegrade cerebral perfusion. So for this, I have an example. This is a short video. This was a selective antegrade cerebral perfusion. Did I share my sound? Yeah.
Yes, we can hear you.
Sorry, yeah, we'll continue. We observed left MCA flow, very strong, immediate appearance of the flow on the right MCA as well, proving that one cannula for selective antegrade perfusion was sufficient to perfuse both hemispheres for selective cerebral perfusion. Very helpful to during rewarming in cardiac cases to recognize cerebrovascular uncoupling that can manifest as hyperperfusion, hypoperfusion, hyperemic hypoxia, or cerebral edema. Take-home message: neuromonitoring provides important information on brain flow velocity changes recognized on TCD and loss of brain activity on EEG. Source of change can be found quickly and timely corrected, as I show on my previous slides. For complete and reliable information from intraoperative neuromonitoring, it is crucial to use multimodality combination. This is what I will, this is the point of my presentation. So we should use EEG, evoked potentials, TCD, and NIRS. In this case, we have a complete picture of what's happening with the brain. If the brain is underperfused, overperfused. Limitations of TCD. Not direct measure of flow, it measures flow velocity. We deal with hyperostosis. It requires considerable skill. We deal with artifact from electrocautery, and there are no adequate prospective studies. However, we are working on it. They should be coming out soon. Nevertheless, with these limitations in mind, TCD is still important and can provide great deal of valuable information, such as cerebral blood vessel to CO2 reactivity and identifying vessel autoregulation, we can talk more about that, how we do it in our surgical room. It quickly identifies venous and arterial obstruction, and we can correct it. It identifies selective malperfusion and gaseous emboli. These are some of my references. There are many. And please contact me with questions or suggestions at this email. I appreciate your attention